Good morning now from Ranger Camp, where all the Oral Board Rangers are working hard and preparing for a decisive victory. I'd like to cover an important Oral Board Beach pillbox today, namely ACLS protocol and how it's changed since December of 2005. Here's a summary of the current guidelines. Compress the chest 1.5 to 2 inches at a rate of 100 per minute for victims except newborns. Push hard, pull fast. Use equal compression and relaxation times. Limit interruptions. Every time chest compressions stop, blood flow stops. Previously, the linkage between blood flow and compressions and the importance of interrupting compressions as little as possible was apparently not sufficiently recognized. The ratio of compressions to ventilations is recommended as 30 to 2 for adults. The duration of ventilation is 1 second, and the goal is to make the chest rise. In adults, use a 30 to 2 ratio for all victims, both 1-person and 2-person CPR. For infants and children, use a 30 to 2 ratio for 1 person and a 15 to 2 ratio for 2-person CPR. If an airway is in place, compressions should not be interrupted, and the rate of ventilation should be 8 to 10 per minute. Immediate defibrillation should be administered as a single shock followed by 2 minutes of CPR, chest compressions first, before rhythm is reassessed for all victims greater than 1 year old. The first shock eliminates ventricular fibrillation 85% of the time. Further, each shock takes an average of 40 seconds. Defibrillation is recommended at 1 year and older. Insufficient evidence exists for a recommendation less than 1 year old. For defibrillation in an adult, the dose using a monophasic defibrillator is 360 joules. The prior dose was 200, then 300, then 360. However, to simplify, the current recommendation is 360. However, reprogramming is specifically mentioned to be unnecessary. It is further stated that few automatic external defibrillators, AEDs, are currently being produced, so biphasic dosing will become more standard over time. If the defibrillator is biphasic and the rescuer does not know the type of biphasic defibrillator in use, the default dose is 200 joules, 150 to 200 joules for biphasic truncated, and 120 joules for rectilinear biphasic. With respect to infants and children now, the initial dose for defibrillation using a monophasic or biphasic manual defibrillator is 2 joules per kilogram. Subsequent doses should be 4 joules per kilogram. In witnessed cardiac arrest, defibrillate first. If witnessed or 4 to 5 minutes elapse before CPR begins, administer 2 minutes of CPR before defibrillation attempts. With respect to additional points on ACLS, in the setting of polymorphic VTAC, the patient is likely to be unstable and the rhythm should be treated as ventricular fibrillation. High energy, unsynchronized shocks at defibrillation doses should be administered. If in doubt as to whether ventricular tachycardia is monomorphic or polymorphic in an unstable patient, shock should not be delayed, so detailed rhythm analysis can be performed. High energy, unsynchronized shock at defibrillation doses should be administered. Synchronized cardioversion is preferred for treatment of organized ventricular rhythms, for irregular rhythms such as polymorphic VTAC, where synchronization is not possible. Further, lower energy levels should not be used for these unsynchronized shocks because low energy shocks have a high likelihood of provoking ventricular fibrillation when given in an unsynchronized mode. Farewell now from Ranger Camp, where all the Oral Board Rangers are working hard and preparing for a decisive victory. As Sun Tzu said, victorious warriors win first, then go to war, and defeated warriors go to war first and then seek to win. Onward now to victory.